Sir, we are live now. Good to go, sir.
Thank you. Good evening, doctors. INTAS has always been in the forefront of supporting academic initiatives for the benefit of the medical fraternity and improved patient health care. I, on behalf of INTAS, am pleased in being given the opportunity of being a knowledge sharing partner in today's program, Management of Tremors, the role of primidone. I'm very happy to introduce to you today's speaker of the program, Dr. Petrus Vadia. Dr. Petrus Vadia has been always in the field of movement disorders. And he has started his own movement disorder clinic, treating the patient with movement disorders as well as spasticity with botulinum toxin, selection of programming of patients with movement disorders requiring deep brain surgery. Dr. Petrus Vadia has a tremendous passion in training and teaching residents of neurology and internal medicine. His affiliations have been that he is the founding member of Movement Disorder Society of India and the Neuromodulation Society of India, as well as a member of many of the international societies like International Movement Disorder Society, Indian Academy of Neurology, Indian Epilepsy Association, Maharashtra Academy of Neurology, and Association of Physicians of India. He has been a very coveted investigator and co-investigator in many clinical trials related to movement disorders and other neurology fields. He has numerous publications in reputed national as well as international journals. He has many awards to his credit, and to name a few, he was awarded the Young Investigator Award for the 26th International Epilepsy Congress in Paris, as well as the Best Platform Presentation Award at the MDS Icon in Chennai in 2016. So I invite you, Dr. Vadia, to please begin today's webinar titled The Role of Primidone in the Management of Tremors. Thank you very much.
Thank you very much for the kind introduction and the invitation to give this webinar. Could you please unshare, sir, so that I can share? So today's topic is basically management of tremors. I mean, first understanding what are the different types of tremors that you will encounter in a normal clinical practice, and understanding where does essential tremors come in, and what are the treatment options in essential tremor, and what is the role of primidone in essential tremors. Now, primidone is a very old drug. It's been there for almost 30-40 years. Till about 4 or 5 years ago, primidone in India was available only in a large strength of 250 milligram tablet, which was actually the biggest bugbear because, I mean, very difficult to titrate. It causes a lot of dizziness, sedation. We now, thanks to the efforts of a lot of the pharmaceutical industries and INTAS included, now have a lower strength, which is available in the form of 25 and 50 milligrams. And honestly, I think the number of primidones for prescriptions have, I think, shot up in proportion, thanks to the new formulations of primidone. And I think I'm here to try and tell you what is the position of this lower strength formulations in the treatment of essential tremors. So tremor is an involuntary, rhythmic, oscillatory movement of a body part. It's different from myoclonus, which is jerky, and chorea, which is irregular, and dystonia, which causes positioning. So recently, there has been a change in the entire tremor classification. Tremor classification has been divided into axis 1 and axis 2. Axis 2 really talks about the etiology of the tremor and whether it's genetically acquired or idiopathic or whether it's due to certain gene mutation or drug. On the other hand, the axis 1 really looks at history, clinical examination of the tremor, associated neurological signs like you might have ataxia, you might have dystonia, or you might have soft signs like you might have other features like a presence of the Kayser-Fleischer ring, and then certain diagnostic tools which might help you to come to a further diagnosis. So I'm going to go through some of this. sorry. So when you go into the things, then we'll also talk about the things that activate a tremor. Tremor is known as tremor at rest. So a classic Parkinsonian tremor is tremor at rest, and you'll understand this better when we come to the videos. And then you have tremor at action. Action tremors can be postural, that when you're stretching your outstretched hand, or it can be kinetic when you're doing a task or writing, or intention when you're doing finger nose finger ataxia, and it could also be an isometric tremor. Then tremor frequencies, although they're very well described, really have very little role to play. The only tremor frequencies that are important I will highlight, especially orthostatic high tremors, which are high frequency tremors. Most tremors are in the range of 4 to 8 hertz, so that really doesn't necessarily help you. And then there are associated signs which you need to understand. You can have a tremor which is isolated, where the only thing that you're getting is a tremor, or you can have tremor combined with other neurological signs like dystonic posturing, rigidity, bradykinesia, or myoclonus, or as I mentioned, systemic signs like a Kaiser pressure ring, hepatosplenomegaly, or an ophthalmology, exophthalmos, which will help you to understand that this is a tremor due to thyrotoxicosis. So another part of the axis 1 is identifying the tremor syndromes. So if you look at the tremor syndromes, you can have an action or a rest tremor, which you can have essential tremor, and a new entity which is defined as essential tremor plus. You can have an isolated segmental action tremor, isolated rest tremor, or an enhanced physiological tremor. So these are the standard action or rest tremors. You can have focal tremors, which I'll really not be talking about, especially palatal tremor, which is a very specific focal entity. Then you can have task-specific tremors like a writing tremor or a musician's tremor. Then you can have orthostatic hypotension tremor, which is a tremor only when occurs when standing in a particular position. It doesn't occur in other positions at all. Then, so these are the tremors where all that you're seeing is mainly a tremor. Then you have a tremor with predominant additional signs, like you have a tremor with dystonia, with Parkinson's, with ataxia, or with other features like a Holmes tremor, which I'll elucidate later. And of course, rarely you can get a functional tremor when the person has got extreme stress. That could be a functional tremor. So an essential tremor is an isolated tremor syndrome. There are no other neurological features. You don't expect dystonia, you don't expect myoclonus, you don't expect ataxia in this situation. The definition that has been changed in the recent classification is that it should be at least 3 years in duration. The reason is that you can get a small postural and kinetic tremor early on in Parkinson's disease, but then as the disease evolves, you will get other features which will tell you that this is not just an essential tremor. To safeguard the evolution of the disease into some other feature, they put a 3 years gap. So it has to be minimum there for 3 years before you actually call it essential tremor. Before 3 years, you'll call it as an isolated tremor. It could be with or without tremors in other locations. So you could get head, voice, or lower limb tremors. And there has to be an absence of other neurological signs. So this is an example. Please listen to the video, and I'll be stopping to talk once I play the video because I want you to listen to the audio. And if I speak, the audio will be muffled. So listen to his speech. You'll hear a tremor in the speech. And when he's asked to say, ah, listen to the tremor. And that's what you'll see the typical voice tremors of essential tremor. So this is a gentleman with long-standing tremors. He's got tremors involving his speech, his hands. There's a positive family history, and he's got difficulty in writing, and that's why he was here. He was admitted for another reason to the hospital. That's when we examined. Sorry. So when you saw that the tremor in the voice, you could hear the tremor go, ah. So you could hear the tremor in that voice. Now you can see he's got postural limb tremors. So you see posture on outstretched hand, and then you put the hands together, but you don't let them touch. You can see the postural tremors here. Now we'll ask him to do finger, nose, finger, so that you'll get an action tremor. This is not an intention tremor, which is just only when you're reaching the nose. It's there throughout the action. And then you can see when you asked him to make him draw a spiral, he's got a marked tremor. You can see the spiral going completely out of hand. And now he's asked to do the spiral with the left hand. And this is the best way to figure out how bad the tremor is and get the severity of the tremor. Now, we did give him a reasonably high dose of propranolol and his tremors weren't controlled, so we also added primidone. You can see a significant reduction in the postural and the kinetic tremor. The voice tremor is much less. And this is the spiral. Remember, when you're drawing the spiral, the hand should not be supported on the table. And you can see a much smoother and less tremulous spiral. And the left hand was very, very bad earlier. That also has improved. So you can make a difference in the quality of life of a person with tremors by using propranolol or primidone, or both, as in this case. So that's the message here. And also to highlight all the features of essential tremor. You don't get a resting tremor in essential tremor. So it's an isolated tremor syndrome, at least 3 years. We've talked about this. And the classification allows multiple etiologies, and there should be absence of neurological signs. The classical features, usually upper limbs 95%, but you can have head tremors in 34%, voice in 12%, and also leg tremors. And they're usually symmetrical, postural, and kinetic. There is an entity which they described as essential tremor plus in the new classification. Basically, these are tremors with signs of uncertain significance. So if you have a mild impaired tandem gait, questionable dystonic posturing, but not in so the tremor should not be in the dystonic hand. The dystonia is in another part, or subtle memory impairment, or mild neurological signs which are not very of unknown significance. That's when you'll call it ET plus. There's a lot of argument about the entity of an ET plus where it can become a drag-back diagnosis. But remember that ET and ET plus are both syndromic diagnoses and they don't really tell you the cause. So the exclusion criteria for ET and ET plus is if you have focal tremors, orthostatic tremors, task and position tremors, and sudden onset or stepwise deterioration. Another entity in the new tremor classification is isolated tremors. You can get just upper limb tremors before 3 years, and many of them may actually evolve into ET or some of them in Parkinson's disease. The other entity, which is I think very, very common in practice, is the enhanced physiological tremor. We all have an 8 to 12 hertz tremor, which is normally present in us. And if we are going for a BiBAB OC, for example, or in a job interview, we'll all have little tremors of the hands when we are anxious. So some people, this physiological tremor might get exacerbated, hyperthyroidism, drugs, anxiety, fatigue. All of them can exacerbate this tremor. And I've even seen some of them in the recovery of COVID who has a slight enhancement of the physiological tremor. So physiological tremor can come up when the body is stressed out, usually needs a lot of reassurance and nothing more than that, and maybe a very low dose of propranolol to reduce the anxiety. So that's the enhanced physiological tremor. This is the orthostatic tremor, which is a very high frequency tremor, isolated tremor. It occurs only when standing, and usually you need an EMG confirmation. Now, this is a video of a person with orthostatic tremor. Now, the challenge is it's very difficult to see on a video because you literally have to feel the tremor. So you actually have to hold your hand on the thigh to actually feel the tremor rather than actually see it. I am showing you the video. Just pay a close attention. You will see subtle movements of the legs when he stands without. You can see subtle leg movements here, but it's not very easily visible. You can see the little tremor here if it's visible on your screens. I've asked him to just stand at ease and see whether the tremor changes. It doesn't really change too much. Again, when he stands on his feet together, he has the tremor, he's feeling it, and there's a subtle tremor which you can see, not very well. Then we are asking him to put his weight on the table. That automatically changes the whole equation, because orthostatic is because of pressure, is because of putting weight on the legs. So the moment you shift the weight onto the hands, the tremors reduce a little bit. But it's still there. You can still see the tremor a little bit. And then when he shifts his weight back, again the tremor starts a little bit. These are not very easy to appreciate on a video. They are more better appreciated when you palpate them, and they have a classic EMG signature. So from the orthostatic tremors, we move on to the tremors with predominant additional signs. And these are the ones that you have to really look carefully during the clinical exam, because your diagnosis is made instantaneously. So this is dystonic tremors. Dystonic tremor is a tremor that occurs in a body part affected with dystonia. So the tremor and the dystonia should be in the same body part. So if it's a head, your dystonia should be in the head and the tremor should be in the head. Head tremors, I would say, are more often dystonic than essential. While on the other hand, probably you have to look very carefully for the dystonia. Now you can see the tremor come up in the left upper limb. It's sort of like a tremor, and you can see him now writing with doing a spiral, and you can see the tremor in the right hand when he's drawing it. Now when he's writing with the dominant hand, there's a little bit of posturing of the hand. Now when he's writing the non-dominant hand, look at the mirror movements and the tremor that's coming up. And also see the fingers going into posturing. You can see extension of some of the fingers coming up as he writes. Especially the index finger is developing extensor posturing. So this is dystonic tremor. And here you can see the mirror movements, and you can see the dystonia of the hand. Dystonia and the tremor are in the same limb. These are examples of Parkinsonian tremors. Now I'm going to mute all of them. And I'm going to play them all together. You can see that this is very subtle, but then when he's asked to speak and do mental calculations, the tremor increases. This is a classic rest tremor, which increases when you start asking him to do distractive tasks. This is a more prominent resting tremor, and it's bilateral. There's a little bit of jaw involvement as well. And often a Parkinsonian tremor will come up when you're walking. This is a lady with a jaw tremor and a hand tremor, and there's another gentleman there behind. And this is a hand tremor and a jaw tremor, both. So these are all classic Parkinsonian resting tremors, which are very clearly differentiated from the dystonic tremors or the essential tremors. So this is a gentleman with ataxia, and he's from the Agarwal community. And he presented with postural tremors, intentional tremors, vocal tremors, you might see. The ataxia often occurs late. So initially they might have a same phenotype as essential tremors. And it's only later on that you'll actually get to see the Now you can see he's got a postural tremor, and he's got finger nose finger ataxia with an intention tremor. I mean, I'm not even asking to do finger nose because I mean, he's so ataxic, he'll bang his nose. There's no bradykinesia, which you'd expect in a Parkinsonian disease. So he's just got ataxia with tremors. So his gait is not too bad, but now make him tandem walk and see what happens. And he can't tandem walk. So ataxia may occur late. So if a person is from an Agarwal community with postural and kinetic tremors, I would send off an SCA12 right away, even if it were to be essential tremor. Ataxia might come much later. Obviously, they don't respond to propranolol, primidone, and the prognosis is quite different. You might get extraocular movement abnormalities, rigidity, bradykinesia, dystonia in certain amount of patients, but some of them have a very, very benign cause. And this is due to a CAG expansion in the region of chromosome 5. Sorry. And then this is the most distressing tremors to treat, the Holmes tremor. Holmes tremor has resting, postural, and intentional. It's usually due to a lesion in the red nucleus, and it's usually got a lot of proximal muscle involved. Look at how severe this tremor is. And look at the other lady, how severe it is. Both of them are asymmetric. You can see this is left-sided more, this is right-sided more involved. And you can see they have a resting action and an intention component. And finger nose finger ataxia would be significantly affected. This lady actually had a bleed in the cerebellar region, causing the tremor, and you can also see she's ataxic. So many of them, apart from the tremor, have brainstem signs, and that is why they are in the category of tremor with additional features. So this is just some features that will help you differentiate. So essential tremor is mainly action and postural, whereas Parkinsonian is mainly resting. Dystonic is action and postural, but you can occasionally get a little bit of resting. Common upper limb presentations would be the bilateral, slight asymmetry, so usually wrist involvement in essential tremors, while finger involvement may be seen in Parkinson's and dystonic. So essential tremor will be mainly wrist, not finger involvement. And also alleviating factors, alcohol, it's not really a major criteria, but yes, if you get some relief with alcohol, that helps you for the diagnosis of essential tremor. In dystonic tremor, if you get relief with a sensory trick, that helps you. And during spirals, your spirals will be normal size. You can get micrographia, and here you can get dystonic posturing when you're drawing the spirals. Intention tremors may be present, usually not seen in Parkinson's and not seen in dystonic. And associated limb signs are none. You might get bradykinesia, rigidity, and you might get posturing in dystonic. And as far as voice is concerned, you can get voice tremors, you can get hypophonic speech, and in case of an adductus laryngeal dystonia, you might get a dysphonic speech. And neck tremors, you'll have no pain, not seen usually in Parkinsonian tremors, and if you get dystonic tremors, you'll get hypertrophy of muscles and dystonic posturing. So we move on to the next section of our talk, the essential tremors and how you manage. So I think treatment of dystonic tremors, you have to treat the dystonia. Parkinsonian tremors, you have to treat the Parkinson's, and there is a role of anticholinergics there. Ataxic tremors, unfortunately, don't really respond very well. Although we do use primidone, propranolol for the want of anything better, but primidone can make the ataxia actually worse. So really, I'm going to focus on the treatment of essential tremors, and there are a host of drugs that have got evidence. The real class 1 evidence is for propranolol, primidone. There is some evidence for gabapentin, some for topiramate, one study with alprazolam, and 1 or 2 studies with clonazepam, clozapine. But real evidence is really propranolol, primidone. And of course, propranolol would be your first drug of choice, especially in a young person. But the main contraindications would be if there is presence of asthma or an obstructive airway disease. And if you have any rhythm abnormalities, especially bradycardia or rhythm abnormalities where the heart rate is slow. And the third contraindication, in my view, is if you have diabetes and you're anything more than metformin, because propranolol will mask hypoglycemia. And that's a fair contraindication, because if you miss your hypoglycemia, you'll have more problems there. So propranolol is not for, I mean, there are a lot of people who will get excluded from propranolol therapy. And that's where primidone comes in really handy. There's also some role of stress relaxation, behavioral techniques, but really not a lot. Botulinum toxin really helps for head tremor. So if you have a no tremor, especially an essential tremor, botulinum toxin injections really help, and you really don't get the same effect with propranolol or primidone. Hand tremors, there have been a lot of studies that have looked at hand tremors with botulinum toxin. You need a fair amount of botulinum toxin and frequent injections, and they're not as rewarding as what you would get with propranolol, primidone, but they have been used in those who are intolerant to either. As far as surgical treatment, WIM DBS, MR-guided focal ultrasound is another option. Thalamotomy is another option. So who should be treated? I mean, essential tremors, anybody who's having social disability due to the tremors needs to be treated. Sometimes the disability is very intermittent. Like I've had patients who told me, Doc, my only trouble is when I'm in a social gathering, and especially if you tell me to go for a buffet and I hold a plate in the hand. Of course, it's not happening in COVID times. But if you tell me to hold a plate in my hand and I'm shaking when I'm serving myself with the other hand, that's my biggest disability. Having soup in public is a big disability. Having a cup of tea, they learn the tricks. They fill it half full and they hold both the hands. They manage that. So many people learn to handle their disability due to tremor. So really, depending on when the disability is occurring, is there disability or not? Many of them are just happy to be told that this is not Parkinson's. It's not going to affect your longevity. They're good with that. They don't want any treatment. On the other hand, they say, okay, just give me something that I can take for a social gathering. And then SOS propranolol works wonders, provided they're tolerating it. So your treatment really has to be tailor-made to the severity of the tremor, the functional impairment, comorbid conditions. So if you have a contraindication to propranolol, propranolol's out. And the patient's preference to treatment, whether they want treatment. Many times they really don't feel that it's necessary. The tremor might be fairly mild and not interfering with quality of life. And they just wanted to hear that, oh, this is not Parkinson's. That's good enough for me. If you decide to treat, what are the treatments? I mean, frankly, alcohol is not a treatment. Really, propranolol, primidone, very effective. I would say topiramate, not as effective. And you need fairly high doses where your paresthesias and all come in. Propranolol, drug of choice, but again, you need to go fairly high. 20 milligrams often just does very well for mild tremors, but you have to reach about 240. Worry about bradycardia, hypotension. Primidone concern is sedation, dizziness, ataxia. And you sometimes, as I've shown you in a study, they've used up to 750 milligrams of primidone. Phenobarbital, not very effective. Benzodiazepines, the only one that seems to have some benefit is alprazolam. Gabapentin, some role. The others have been studied in 1 or 2 studies and minor efficacy. The shortcomings of propranolol is really fatigue is one. Bradycardia, hypotension, breathlessness, and contraindication is COPD, asthma, severe peripheral vascular disease, and diabetes, as I mentioned. Primidone is a very good anticonvulsive drug used for tremor control, and really it's not used for convulsions anymore, really for tremor. Found to be effective in epilepsy as early as 1949. Mechanisms of ET really not well understood. There is some question of whether the role of GABA, but there are also role of transmembrane calcium and sodium ion fluxes, which may be playing a role. The GABA role, questionable. And again, phenobarbital also has been used, but the tremoritic properties of primidone far exceed phenobarbital. And what is the position of primidone in the treatment of tremor. Sorry, this is wrongly done. Tremor is for mild tremor, primidone is class 1. For moderate tremor, class 1, and so is it for severe tremor. And in all of it, primidone is class 1 evidence that it works. So primidone does work, and it's class 1 evidence, and it's there in every treatment algorithm. This is a study that done, most of the primidone studies, mind you, are done in the 80s and the 90s when it actually got regulatory approval. So this is the study from JNNP 1986. They use propranolol, primidone versus placebo, and you can see primidone and propranolol versus placebo significant in all frequencies of tremor, and both of them with a significance of 0.01. And this is the frequency of the tremor, and this is the power calculation on the accelerometer. So you summate the power, and this is a moderate tremor, this is how the power looks. Mild tremor, this is how the power looks. And if there's no tremor, this is how it looks. So on the power spectra, they looked at the amplitude, and this is the amplitude, which is a square root of the standard power, and that's how it's calculated. And the placebo group, you can see high tremors versus the primidone and the propranolol group. So clearly works again. Both of them work, and there's no difference whether it's propranolol or primidone. So they are equally efficacious. And this is a study looking at barbiturate, that's phenobarb, and primidone in essential tremor. This is for hand tremor, clearly significant, P less than 0.01. No, slightly better on the head tremor front, but not significant. So this is a study comparing 250 milligram of primidone versus 750 milligrams of primidone in essential tremor. So they had two groups of patients, group of 250 milligram, group of 750 milligrams, similar patient 56, 57. But 18 patients with the high group abandoned the study, 13 due to undesirable side effects. And here only 2 abandoned because of undesirable side effects. And the efficacy was similar, as I'll show you in the next table. So similar efficacy in each group, but higher adverse event rate in the high dose group. Higher somnolence, higher cephalic discomfort, higher dizziness, higher nausea. So overall, high dose primidone does have fair amount of side effect and fair amount of dropout. So there is a role for using lower doses. And that's exactly what I was saying, that when we've got the new 25 and 50 milligram brand, I think our comfort in using primidone for tremors is much higher than what we had when we were having a 250 milligram tablet. And this is a study looking at alprazolam and primidone and acetazolamide. Acetazolamide not significant compared to placebo, but both alprazolam and primidone were significant compared to placebo in a short, small study, which was a double-blind crossover study. So all the patients were crossed over into each arm, and 22 patients, and clearly showed that primidone and alprazolam were beneficial. So the advantages of primidone over propranolol is similar to efficacy. It brings the tremor under control fairly earlier compared to propranolol, but you have to worry about sedation, nausea, vertigo, which manifests with the first dose. So you have to start very low in primidone. And primidone is also useful in those who either have not benefited with propranolol or who cannot tolerate propranolol because of either the comorbidities or the adverse events to propranolol like bradycardia or hypotension. So what is the status of primidone? Primidone is a first-line treatment for essential tremors as recommended by the American Academy of Neurology. It is most effective. It reduces tremors by about 50%, brings the tremor under control fairly early, similar action, response efficacy to propranolol. Acute side effects, you have to worry about sedation, nausea, vertigo, and imbalance. And they tend to reduce over a period of time, and you do get tolerance because of barbiturate, all side effects tolerate. Primidone could also be effective in individuals who have unsatisfactory response to propranolol or develop adverse events, reactions to propranolol. Personal experience with primidone. when we had the higher strengths, we found a lot of patients had difficulty tolerating. I would start with 1/4 of a tablet. First of all, very difficult. Many of the patients are senior citizens with poor eyesight, and they said, oh, I can't break it to 1/4. So that the battle ends there only. Then they will not break it to 1/4. They'll take the whole tablet. They'll get dizzy. They'll never take it again. So we had a lot of intolerance, lot of dropouts with the higher strength. Somnolence, dizziness, imbalance, main challenges. Now that we have the lower strengths available with 25 and 50, I think it's much easier. We are able to start with 25 HS. I usually go up maximum to 50 BD. I tell them go up only if you're tolerating the drug. Some of them I've actually even gone up a little beyond that. But honestly, we are getting good tremor control at 100, 150, 200 milligrams of propranolol a day. Similar, or primidone a day, similar to the study that I showed you with the low dose primidone study. And I think it's increasingly becoming a first choice in some of the patients, especially who are intolerant to beta blockers or who have already got brittle blood pressure issues, who have already got orthostatic hypotension. Maybe they are on alpha blockers for prostate. Already the BP is very brittle. Primidone is a good choice in many of these patients. So the algorithm to manage essential tremor is first decide, is there function disability? No function disability, you don't do anything. Or just give an SOS medication, a low dose propranolol as an SOS. If there is functional disability and it's a limb tremor, go ahead with either propranolol or primidone. I would do propranolol or next primidone, not gabapentin. This is an algorithm created by somebody else. And this is 2009, before the low dose primidones have come into the Indian market. Head tremor, really botulinum toxin is the drug of choice. If you don't respond, then try the oral medications. And then when you've tried all drugs at a high dose and nothing works, then think of surgical options. Surgical options we have as deep brain stimulation. You have a WIM DBS or you have MRG FUS. This is just an example of a lady who is, sorry, I think the video is, sorry, this is my apology. The video is just not playing. But clearly the BIM DBS video, you can see instantaneously as you switch on the video, the tremor goes away, the spirals get better. Apologize for that video. So tremors are a heterogeneous group of disorders. You need to carefully evaluate the patient to come to a conclusion on the tremor syndrome. Propranolol and primidone are the mainstay of treatment. Low dose primidone is better tolerated and is increasingly becoming the first choice in those where you have either contraindications or adverse events to propranolol. And many times we're using it as an add-on to propranolol, where propranolol is not giving enough tremor control for the patient to have a good quality of life. Thank you very much for your patient hearing. I'll stop sharing at this point and we can take questions.
Yes, sir. Sir, shall I read questions for you?
Yes, please.
Yes, sir. Sir, we have one question from Dr. Ajay Kaushik that do primidone cause sexual dysfunctioning?
So usually we are using primidone in the elderly population. I haven't really checked the literature carefully about it, but propranolol itself causes erectile dysfunction in high doses, by the way. Fair amount of erectile dysfunction actually. So primidone, I have probably not really encountered too many patients coming back on this issue, but largely my tremor population is elderly. So I don't know whether they're really concerned about the sexual dysfunction. But I personally have not come across any experience on my front.
Yeah, thank you, sir. Then, sir, we have one question from Dr. Dracula Kumar. His question is, maximum tolerable dose of primidone used in your clinical practice, and at what interval does it increased?
So I increase it about a week to 10 days. I'm very, very worried about the side effects and tolerance. And if you lost a patient to primidone early on, you'd rather have a lower tremor control initially. So I usually do 25 milligram increments at either 1 week or 10 days interval, depending on what their previous experience with drugs has been. And every week increase the dose by 25. If they are even more jittery, say start half of 25, that's 12.5, and increase it by 12.5. You will play it by ear as to what previous experience with tremor drugs, and if they're very, very jittery, very scared about the side effects, I'd go very slow. The maximum I have used primidone is 3 tablets of 250, which is 750 milligrams a day. But very few people really tolerate that dose. Very few people. And honestly, I'm beginning to use much less. And in the new formulations where we are using 25s and 50s, the maximum I think I've gone is 50 milligram QID, which is 200 milligrams a day. But I do have some of those who are on 250s who are not getting it, who are actually taking about 500 milligrams a day also. But I think I'm using the doses as I've aged and as I've been more, quite miserable at high doses.
Thank you, sir. Then there is another question is from Dr. Lenny Thomas Matthew. The question is there any use in starting pacitane for essential tremor?
No, Pacidine is only for dystonic tremors or for Parkinsonian tremors. There is no role in an essential tremor. And I would desist from polypharmacy because every drug has a side effect. And then you really are struggling. So stay with one drug, reach the top dose, stay on that dose for at least a couple of weeks before you add any other drug. And Pacidine, no role at all in essential tremor, none whatsoever.
Thank you, sir. Another question is from Dr. Sanjeev Suri. His question is, your experience with combination of propranolol and primidone, or you use one drug at a time?
Sorry? I
Yes,
use
sir.
one drug at a time initially. I would not combine them initially. I'd combine them, say if I'm using propranolol first, go up on the propranolol dose, reach the maximum tolerated. The maximum tolerated is up, if the heart rate going below 60 or the blood pressure systolic going below 90, I would really not push harder. So usually 240 milligrams is the maximum I would go in propranolol. On that, I don't think it really benefits. Then once they are on that stable dose, they are tolerating it well, then maybe add a 25 milligram of primidone and gradually build up that primidone dose till the maximum tolerated or till their tremor control is comfortable, both. I mean, whichever endpoint comes first.
Thank you, sir. Sir, we have one comment. I don't know. I mean, Dr. Vijay Kumar has posted essential tremors and surgeon. So
Essential tremor and the surgeon, you can do VIM DBS or Zona DBS, and you can also do focus ultrasound. There is MR guided focus ultrasound, which has been approved for the treatment of essential tremor. But my general take is that most of the Indian patients are not very bothered about either of these entities because they're I mean, the Indian system, they're happy to be helped for their activities of daily living, and they don't seem to be feeling that they're willing to have a surgery to take care of their disabilities. So we've not had too many takers really.
yes. Thank you, sir. So this is what we got from the questions and from the audience.
Yeah, I'm just, since I couldn't play that VIM DBS video, I'm just going to see if I can show you the video of that lady with the Holmes tremor post DBS. I somehow forgot to include it in the presentation. Let me just see if I can get it. Yeah. I'm just going to screen share, just show you one last video before we end for the day. So this is the lady with, and she had a left PCOM aneurysm with an intraventricular hemorrhage and a midbrain hemorrhage, which has caused this horrible, devastating and disabling tremor. Okay, and this is her post DBS. We had done a VIM and a seal.
सामने रखो रिलैक्स होके ये अच्छे से रखो ना ऐसा
The challenge with the VIM DBS is that she's continued to have ataxia, which was a challenge, but you could see that improvement in the tremor. Okay, so if there are no more questions, then we can then probably end the session.
Yes, sir. Thank you so much, sir. Thank you for such a wonderful session. And thank you for giving Intas opportunity to be your knowledge partner in this session. Thank you so much, sir. Have a wonderful day, sir.
Thank you. Thank you, everybody, for joining the webinar. Thank you.
Thank you, sir. Thank you.
Thank you, sir.
Rohit, we can stop the live streaming. Sir has left the meeting, right?
Yeah.
Yes, yes.
Yeah, sir has left the meeting.
Sir,